Hello again. Welcome to IC01, promoting active safety for patient or power wheelchair users with spinal cord injury, recognition and prevention of inadvertent lower extremity injuries.
Hello, everyone, and welcome from us here in bright and sunny Cleveland, Ohio, where the reflection off the snow is quite profound. Again, if you have joined us a little later than some of the earlier people, please try to join our audience polling session at the pollev.com link shown below. We have three main learning objectives for this talk, which are talk about typical patterns of lower extremity displacement-related injuries and the wheelchair features, which might contribute to them. Talk about and explain how you can voluntarily submit reports of injuries to the FDA's MOD database, and talk about active safety approaches to detecting these lower extremity displacements from the wheelchair foot plate. We have a couple of disclosures. Dr. Bogie, Majerus, and Steve Mitchell are all co-sponsors with me of this Smart Foot Position Sensor, sponsored by the VA. And the work to date on the Foot Safe project was funded via a VA Innovation Incentive Seed Award. Our research team, as you can see, we are an interdisciplinary team of clinicians, engineers, but the heart of our team are veteran advocates, Sean Ferry and his wife Lynette, Robert Morris. Sean is actually going to be our lead out speaker today, and while he introduces himself, we're going to start with our initial polls and get to know a little bit about you as well. Sean, it's all you.
Thank you, Dr. Henzel. My name is Sean, and I'm 51 years old and live in a small town in Pennsylvania. I became a C4 quadriplegic 7 years ago. Having a spinal cord injury and being restricted to a power wheelchair has opened a whole new world of daily activities for myself, my wife Lynette, my family, and many caregivers. I have seen and heard of so many injuries due to my lifestyle that I have made it a point to advocate anywhere I can to keep myself from getting injured, as well as everybody in this same condition. On a daily basis, I encounter obstacles in my neighborhood, my local businesses that are ADA approved, and even my own house and yard. I'm so excited that recent research has started including the end users. It is so much more comforting to hear about new inventions and practices that have had involvement from people who will benefit from them. I believe that during many research projects, there is a need for some input for details that may be overlooked. Historically, a very well-educated and qualified group of people work on projects, but could benefit from someone who lives the life. We know that people using wheelchairs can be injured while doing so. And previous surveys found that about half of people with chronic spinal cord injuries, or SCI, have broken their lower legs badly enough to require hospitalization. Sometimes this happens by catching their foot on a door frame while using their wheelchair, but we also know a third of people using power wheelchairs are running into objects in their environments, and these incidences can cause injuries requiring an ED visit. Next slide. As you well know, people with SCI have varying degrees of muscle control, sensory loss, muscle spasms, contractures, weight gain, and osteoporosis. These issues make us more prone to problems with our wheelchair positioning, which we cannot always control without assistance, and to injuries like broken bones. Before we move on, I'd like you to sit up straight in your chair with your feet flat on the floor. Without bending over, look down and think about whether you can see your feet and know where they are. You may also notice my crisscrossed strapping for my upper body. There are many people in wheelchairs that have no core strength or upper body movement, so I do not even have the option of bending forward and looking to see where my feet are. Next slide. I'll bet that most of you cannot see your feet, but you can feel where they are. Our team believes that one of the biggest problems driving wheelchair-related injuries, which is funny because driving causes the wheelchair injuries, for people with SCI, that is we lack sufficient feeling in our legs, and our feet are not in our line of sight. We also may not have the muscle control to bend over and check our feet. And some of us, as I stated, need straps to keep ourselves upright in our chairs. Next slide. We believe, and research that we'll talk about later in this workshop bears out, that injuries seem to happen when our feet don't stay squarely on our foot plates. You can see in this cover photo from the PVA's Paraplegia News an example of how this can happen. Steve Mitchell came up with a term for these events, inadvertent lower extremity displacements, which we have shortened to ILEDs. When an ILED happens, if they happen at all, for someone who uses a wheelchair for reasons other than nervous system problems, they usually know it happens and can just reset their foot on the foot plate. Next slide. But remember, people with SCI can't see or feel where our legs are, particularly in relation to objects in our environment. Next slide. And we may not have the muscle strength to control our body position while driving or be able to put our feet back on the foot plates if an ILED happens. Next slide, please. We also don't always have a choice about the terrain or environmental conditions of the sidewalks and streets where we live. As an extreme example, some of you in Pittsburgh might recognize Canton Avenue as the steepest street in the continental US, with a 37% grade, which is definitely not ADA compliant. And it's also partially made up of Belgian block, which makes for a bumpy ride. I would not want to be someone who has to live there with an SCI. I'd like to close out my section by showing you a photo staged by my wife, Lynette, of where my foot ends up when it comes off my foot plates. It does not happen all the time, but usually occurs if I have a muscle spasm while I'm extending my leg rests and it comes off the side of my foot plates. I have a complete injury, so I cannot feel it when my foot is positioned like this. If I drive forward and my toe catches on the ground, well, then I'm screwed. I've talked to others in the SCI community about this, and ILEDs are a pretty common problem that happen differently for different people. So far, I've been fortunate to escape serious injury with the help from my family and caregivers, but that's not true for everyone. I am hopeful that the work of our team and all of you will lead to strategies everyone with SCI can use to avoid ILEDs and subsequent injuries. I sincerely appreciate the work that all of you are doing to help people like me. I know you would not be watching this presentation if you are not willing to help. Dr. Henzel is going to take it from here to talk about the medical consequences of ILEDs.
Thanks very much, Sean. So we're going to do another poll while I start this introduction and to see if any of you have ever thought about these lower extremity displacements as a problem for people with spinal cord injuries who use powered or non-powered mobility. We started becoming aware of this problem, or at least I personally became aware of this problem around 10 years ago when I was a baby, brand new out of fellowship physician, and Steve Mitchell came to me with a case where he said, I think, there's a problem with the wheelchair and that this is leading to this injury. So our next slide that you'll see after we give you guys a little more time to respond, reports a case series from our VA. We have, between 2012 and 2021, documented 17 vets with traumatic ILED-related injuries. 10 of these were hospitalized, and they tend to have long lengths of stay. And we did an analysis of those 10 inpatient hospitalized veterans and found that the total cost for VA DSS data was $970,000. It's about $100,000 per hospitalization. You think that's in the VA system of care, which provides a little bit more comprehensive and longer lengths of stay, perhaps, than the private sector. But the impact for the individuals with the injuries can be quite profound. So I'm just going to move ahead. And just as a warning, we're going to show 3 patterns of injury, and 2 of those have somewhat graphic images, which I, as a physician, don't faze me. But for those of you that don't do soft tissue work, it might be troubling. So the first injury pattern that we've observed are abrasions. These can be quite severe, as you see in this case. This veteran, well known to us, was driving in and around actually the medical center, and his foot came off his foot plate. He doesn't know how long it dragged, but he sustains very severe injuries. And in the middle picture, where the big toe is, you actually see some exposed bone. And so he had to have an amputation of part of his foot, his first great toe, and some tissue on the second toe as well. And that was a long stay with medical complications. The second injury pattern that we've seen are fractures. These are probably the most common thing we've seen. And this particular x-ray is actually the first eyelid that I knew about. This individual caught his shoe on a door frame as he was turning. He also had a very long length of stay, and we'll hear from him later, talking about the impact on his quality of life. And finally, pressure injuries. We don't have any particular case example here because they're so common. And there are a number of contributing factors, including pulmonary flexion contractures, equinovarus deformities, what footwear someone may or may not be wearing. And the most common locations that we've identified these to occur are the heels or the 5th metatarsal heads. But depending on positioning, could be other locations. So what patterns of injuries have you personally seen related to eyelids? And that's a question that we have, and I see we already have some responses here. We also have a large number of secondary complications, which I'm going to talk about while you guys respond to this slide. Like our first example, we've seen a small number of people who have required amputations. Typically, that has been because of an abrasion injury, but we've also seen people who required amputations as a sequelae of a fracture when they sustained a pressure injury from their cast or their splints, which went on to become necrotic with gangrene. But people also often end up not being able to use their wheelchair when they're recovering. And they end up, possibly on bed rest, they get deconditioned. It impacts their mood because they're socially isolated, and it reduces quality of life. Now, unfortunately, one of the complications that we've also seen are deaths. Or heard, we haven't seen these personally, we have heard reported. So one was a news report here of a Army veteran in Virginia who was found dead in his wheelchair. And we've also heard a verbal report at one of the PVA meetings of someone who was, I think, playing wheelchair tennis and died due to abrasions while on blood thinners. So we really can't downplay the impact that these injuries have on quality of life. For example, our first veteran with that incident eyelid that we noted, complains of losing 5.5 months of his life. It limited his ability to engage in volunteer work. He missed family functions. It was very frustrating to him. And next, we're going to pass the baton on to Steve Mitchell, who's going to talk to us about how complex power wheelchair design and clinical considerations factor into this.
Thanks, Dr. Henzel. So how do we get here? 2011 actually was kind of a hallmark time because that was when Permobil introduced the M300 at ISS, and I don't know how many of you were there for the introduction, but it was very fortunate that it didn't turn out to be a debacle, because you see they had half their sales force at the exhibit and half the sales force was getting trained on the product, and they had these rainbow ramps which they kind of went up at a fairly steep angle. They were, and then you get to the top and then you could drive down, and they were at their factory programming settings. And the manufacturer assumed that therapists know how to drive power chairs, and that factory settings are always controllable. Fortunately, nothing happened, but it's when this was a unique case where a manufacturer assumed something about therapists. Oftentimes, therapists assume a lot of things about products, and sometimes some things can kind of sneak up on us that we don't necessarily realize. And the reason why Permobil's introduction of the M300 kind of marked an era of mid-wheel drive configurations with power center mark platforms was because they were the primary manufacturer of front-wheel drive models, and everybody else was already primarily making mid-wheel drive models. So it would change things for, I would say, the next decade. So for the most part, that was a good thing. Compared to a similarly equipped chair with a swing-away leg rest, you would definitely get a smaller footprint on the chair. Basically, when you look at any power chair that you're prescribing for an end user, you're trying to balance 4Fs: form, fit, function, and footprint. And mid-wheel drive with center mount leg rest for most users does a very good job of providing very good function and a very small footprint while accommodating the needs of the user. But it's not, and let's advance to the next slide. Here we have two identical TDXs that have the same seat size and everything. And if we look at the overall lengths, swing away versus center mount, it's significant. There's about a 4-inch difference. All that 4 inches is directly reduced off the turning radius of the chair, which would be from the center of the hub to the longest point, which in both these cases is the end of the foot plate. So that does make it a lot tighter, more durable as well. And this chair, for instance, passed the ultimate maneuverability test, which is our service elevator hallway, which is only 45 inches wide. The chair could turn within that space. Not many power chairs can do that, but the ones that are typically going to be mid-wheel drive models with center mount leg rests. But for some users, this was a problem. A problem that I like to say is hidden in plain sight. And that's because on almost any mid-wheel drive model, the usable space between the front casters for the footplate is less than 11 inches. And for many of our users, especially for my population, which is mostly adult males, less than a foot of space isn't enough space for 2 feet. This is a size 11 shoe. On the left is Permobil's narrow foot plate. On the right is Quantum's, and you can see there's not a lot of room. And one of the big things that we have is a lot of the people that I work with, their feet are not going to stay comfortable either. They're going to want to migrate outward because it's in too close for what their body structure is. And manufacturers vary in their design, some better than worse. But there's a hard reality, and that's that there's less than 11 inches of space there. And one of the things we don't always consider is, let's think of the last decade. And until this year, when Quantum came out with the Forefront 2, all the HD wheelchairs that were power chairs that were manufactured were mid-wheel drive models. But is mid-wheel drive always going to be the most maneuverable? And a lot of times I think we have to, again, assess instead of assume. There's no hard and fast easy rules except in complex rehab technology, except there are no hard, fast, and easy rules. So if we take a look at a 17 by 21 Permobil M3 with narrow foot plates, you'll get an overall length of about 45.5 inches. But if that individual needs wide foot plates, and you have to elevate the leg rest out to clear the casters, that effect, in order to have no speed reduction, the overall length of the chair effectively becomes 49.5, which is actually a tad longer than the TDX with swingways as I showed in the previous slide. And again, that extra length is added to the turning radius of the chair. So considering that, let's look at that same 17 by 21 M3 with the leg rest out because it has wide foot plates, and compare that to a comparable Permobil F3 that has the same seat dimensions. But because of its configuration, you can bring those wide foot plates into 90 degrees. then you're looking at a 4-inch reduction compared to the M3 with the Allegris out. And again, that all counts towards the turning radius. And if you take the turning radius for the front drive model and kind of put it next to the mid-wheel drive model, like I've shown here, you can see it is slightly longer, the mid-wheel drive. So mid-wheel may not necessarily be the ultimate maneuverability for certain users. Some users also have secondary complications that can be extremely difficult to address. One thing would be heterotrophic bone. In this particular user, their left hip does not achieve 90 degrees of hip flexion. So as a result, their seating must accommodate that downward slope of the femur. And you can see the difference in the height of the leg rest. If we don't accommodate that, and the person has no sensation, more than likely that pressure is going to be, and that force is going to be transmitted onto the foot of the end user. Again, if they don't have sensation, they won't be able to feel that. So it could be a problem that we're totally unaware of unless we're specifically looking at it. Again, assess instead of assume. Then we also have contractures and pressure injuries, which are very prevalent. The case on the left was actually somebody who had severe deformities due to ankylosing spondylosis. The strap above the leg, above his ankles there, is not to prevent an eyelid. It's actually because the chair has 10 degrees of anterior tilt, and that's kind of substituting for the knee blocks to allow him to kind of get more functionally oriented to what he's doing, because he's contracted at multiple joints and extensions. So it's a very posterior oriented posture. And then there's Prevalon boots and pressure injuries. And Prevalon boots are the worst possible thing to wear when you're in a complex rehab power chair with center mount foot plates, or with any foot plates actually. And ideally, it's better to get other footwear. But footwear itself, whether a person's wearing it or whether they're not wearing it, is going to determine how securely their feet are on the foot plates. Somebody that normally goes around with shoes and is going around in their power chair without shoes is not going to have the same degree of contact. Likewise, if they change cushions, same situation. So those are just normal conditions that people encounter where they're not going to have the same containment and securement on their foot plates. And spasticity, and most of the time this is going to be an extensor spasm where it's going to go off the front, but sometimes end users have flexor withdrawal. In this case, this person tended to go in a flexor withdrawal a lot and tended to adduct at the hips. If you try to strap such an individual by putting a toe strap on the foot plate, odds are that toe strap is just going to start irritating the foot as it's spasming off the foot plate, which just makes the spasming worse. So the better idea is to try to do containment. So in this case, we made a little calf panel out of honeycomb to be able to kind of cushion the heel when it came back and hit it would hit that instead of a calf pad, so it wouldn't get irritated, and it would kind of calm it down. And then there was a strap mounted on his thigh support there to limit the amount of adduction that he would spasm into. But usually it's going to be extensor spasms right off the front. And then there's also edema, lymphedema, and also the tendency for people to frog or externally rotate and abduct at the hips, which for many larger users and just a lot of the veterans I see, this can be a significant problem where securement is definitely an issue. In this case, he's rotating to the point where his upper legs are coming off the corners of the seat, which is definitely a warning sign. He's got his computer laptop behind him, so that's not helpful either. But to effectively address that, we had to go with the front wheel drive model, beef up the lateral thigh supports by installing headrests instead, and we did a custom to get the extra wide foot plates from the M300 HD with their lateral rotation feature to be able to contain the feet. But you can see that would be very unlikely you'd be able to accomplish that on a mid-wheel drive model. Okay, and then, but it doesn't matter necessarily if somebody has one of those unique problems. The fact of the matter is any end user is going to have issues with their positioning and power seating because the relationship between actuators and hinges is inherently imperfect. This was taken using a upper or lower extremity prosthesis with Permobil's VS leg rests. This one, so the pivot points of the prosthesis would be roughly where the knee is, but the pivot point of the leg rest is different. And in order for the foot plate to kind of keep up with the foot, it has to be able to extend. When engineers designed this, I'm assuming that they had designed it for their Corpus 3G cushion, but putting the user on a Rojo would change the location of the knee. So you can see there's a lot of variables involved whenever there's a joint and a hinge for a power seating function that's trying to match that movement. So as you see, as it goes up, we've got a fixed length in the leg, but you can see that the foot plate actually out-articulates the foot so that there's a gap there. And then as it gets to the very top, it comes in a little bit. That's going to happen a lot of the time for people. If they don't tilt and they're not using the other power seating functions, it's probably going to push them back in the seat. But for most individuals, if we do a good job and we teach them to use their power positioning for pressure redistribution, nearly every user's feet are going to lose contact with the foot plates if they fully tilt and elevate their leg rests. And that's because essentially a weight shift is really a position shift. So when that person gets back to around 40, 45 degrees, they're going to unload and they're going to slide back in the seat 2 inches. This is actually Sean's first chair, which was one of our first F5s, and it had a sip and puff head array, one of the last proximity switches based systems I did. And if you want to find out why, attend my session later this afternoon at IC 33. But you could see this is almost like an inversion table. So if this person, or in this case of Sean, if he wasn't using his thigh supports and he wasn't aware of the issue, the seat would definitely lose contact. They could very easily roll off. What oftentimes happens is the foot partially loses contact, and then what happens to it when they come back down? Typically, it'll be partially on the foot plate. If they're not aware of that, then that sets them up for an eyelid-related injury. And this is just a picture of Sean's chair now. He uses a proportional joystick and a F5 stander, and a lot of that has to do with his hard work and not wanting to be on that sip and puff head array. And I don't blame him. So it was a pleasure to be able to do this chair. So once we understand the nature of the problem, it becomes possible to develop common sense solutions to minimize a user's risk of eye-related injuries. If we see that when they do their pressure relief, the foot plate out extends their foot and they lose contact, well, maybe when they do pressure distribution, maybe don't bring the leg rest up as high, limit it to 10 to 15 degrees short. If they're using the chair and they're driving out in a rougher terrain or over a bumpy sidewalk, instead of having their feet down at 90 degrees out of view, elevate the leg rest 20 degrees or so that it's in their line of sight so they can monitor their feet. That's also going to help contain the feet. And also with device selection, always make sure that we're selecting when a person's positioning dictates it, prescribe front wheel drive over mid wheel drive. With that, I'll turn it back over to Dr. Henzel.
Okay. So I'm going to talk a little bit about the importance of medical device incident reporting next. Oops. My Zoom controls are getting the better of me. So you all know that medical device reporting is the use of tools from the Food and Drug Administration for tracking device-related deaths, serious injuries, and malfunctions. And this allows the FDA to identify potential device-related safety and performance issues. Here's what the landing pad looks like, and I'd be curious to know how many of you who are not mandatory reporters have reported an injury using the MedWatch website. Mandatory reporters are the manufacturers, and they will report both deaths related to device use as well as device malfunctions that could potentially contribute to death or serious injury. The importers also are mandatory reporters, and they will report to the FDA and the manufacturer when they learn that a device may have caused or contributed to death or serious injury, and they report to the manufacturer those sort of malfunctions that could be dangerous. Device user facilities are required to report to both the FDA and to the manufacturer when there's a suspected death, but they only report to the manufacturer when there's a medical device related serious injury, unless they don't know who the manufacturer is. And then they are required to report to the FDA within 10 days of any medical device related serious injuries. Now, all of us, the rest of us rather, are voluntary reporters. And so all healthcare providers, patients, caregivers, and consumers are encouraged by the FDA, looks like we topped out here, to report voluntary medical device reports of any adverse events or product problems. And so I'm going to go ahead and show you the website, and we talk about how you do this. So once you end up on the landing page, I've got the website there at the bottom. You would click, if you're a medical professional, the far right green button to report a medical device problem. This takes you into the MedWatch portal and will allow you to electronically complete the FDA Form 3500 if you're a health professional. And if you're a consumer or a patient, it's Form 3500B. Now, what's nice about this is that you have 3 days to finish the report. So if you're like, oh, I don't have all this information, you can go back in after you get it within 3 days and continue it as long as you've written down your code. You're going to fill out demographics on the patient, no identifying name or social security number. I still don't know what the patient identifier should be, but it's not identifying information, PHI. And then you're going to describe the problem in detail. And so is it going to be an adverse event? In most cases, that's what we would encourage you to report. This could include, they give options of death, life-threatening injuries, hospitalizations, disabilities or permanent damage, other serious or important medical events, and did it require intervention to prevent permanent impairment or damage? And you can multi-click here. You give the approximate date of the event. This next section has to do with whether something is a medication typically. It's under an emergency use authorization. And then you describe the event to the best of your ability. Moving on, you skip the section about product. This is for medications, but not for devices. And then you would go on to the device. And as best you can, you would then fill out the brand name, the manufacturer, model numbers, catalog numbers, et cetera. And then the last steps include identifying yourself, reviewing the data. Those are the other sections are less interesting, and therefore I'm skipping those. But what is really interesting about the FDA data is that it is searchable by any of us. It is open access using the manufacturer and user facility device experience database. Now, the MOD database is not perfect. It was never designed to categorize incidents of events. And it's limited by the fact that, voluntary reports are limited perhaps by time, and mandatory reports, there is no enforcement that a manufacturer report. And of course, if the manufacturer doesn't know that it happened, they wouldn't do the report as well. Reports may lack full descriptions, and it's possible that there's a duplicate from a manufacturer and a healthcare provider. But despite these deficits in the MOD database, we decided to try to get a better understanding of what was going on in these events by doing a small analysis. We looked for either manual or power wheelchairs and injury in the MOD database, pulled about 1,100 reports and reviewed these. 29 reports described wheelchair-related lower limb injuries. The majority of these were occurring in power wheelchairs. But the most interesting piece here is the mechanism of injury. Well, one of the most interesting. And what you see here is that in 59% of the reports, they directly describe that the foot slipped off the foot plate. In another 7%, they described the foot hanging over the foot plate. And another 21% described them catching between the foot plate and something, which implies that the foot is not properly on the foot plate. They also describe bumping into objects as well as banging on the foot plate, which I think may sort of describe injuries related to pressure. Of these injuries that were reported, the vast majority involved fractures, as well as wounds and some amputation. The other very interesting thing that we found here was that, the manufacturer comments almost unanimously described the cause of injury as being related to end user error, rather than hardware, software, or misprescriptions. We'll give you a couple of examples of reports. And here, of course, the lawyers, I'm sure, were involved in the writing of the user manual, saying, that the user's feet must remain on the footboard while operating the chair. And if they don't, then they might cause an injury in contact with the caster. The manuals, warn the end users to avoid steep ramps, to stay properly positioned, and to avoid uneven terrain. And as we previously mentioned, those are not necessarily possible for people with spinal cord injury. So this leaves us with the question, are fractures, wounds, and amputations inevitable consequences of wheel mobility by people with spinal cord injury? And I like to think that this is not true. And so we're asking, can some traumatic lower extremity injuries be prevented? And I'm very pleased to be speaking after Barry Dean. The LUCI system is something that we have considered in our active safety perspective. And we think that these are very synergistic sort of responses. So Kat Bogie is going to go next and talk about how we have conceived of using item detection to drive active safety. Kat, go ahead.
Thank you, Christy. So we have discussed so far the problem that we've seen and the challenges of wheelchair design matching with people. And you'll have heard, if you listened to the keynote from Barry Dean, about active safety. Next. And as he mentioned, there has been a lot of work done on active safety, particularly in the automotive industry, where if you have a newer car, you probably have sensors on the car, which has sensors which will look at the external environment. It gives you, as a driver, information about obstacles or in the periphery of the car. Next. But there is two components. There's an external locus of active safety. There's also the internal locus. How safe is the driver in their car? And with cars, in vehicles, you have sensors for drowsiness and attention deficits, and alerts to make sure you keep in the lanes. Next. What we have been looking at is similarly looking at how do we monitor people's position, particularly their feet, when they're in their wheelchair. And this is not in opposition to LUCI. This is more of a complementary system because it has an internal locus as opposed to the external locus of avoiding bumping into obstacles. It does allow us to detect, the goal is to help maintain foot position on the foot plate and to detect where their foot is in relation to their wheelchair. Next. So the system that we've developed, which is called FootSafe, includes at the current version, includes both pressure sensors and IR sensors, which allow us to monitor the pressure distribution of the foot on the foot plate and also the displacement of the foot from the foot plate. So the interface application we've developed does real-time data collection and runs a detection algorithm so that we can not just measure it, but also interrogate the data to see if the foot is displaced or if it's completely off the foot plate. And it gives user feedback. So next, please. So this is a slightly complicated engineering type drawing. Image. So the initial concept that we had was to have multiple force sensors across the foot plate. And we went back and forth deciding, do we want to have about 50 sensors in the same way as you would with a seating pressure interface sensor? or can we get away with less than that? And at the moment, we're still trying to refine those. But what we do know is that we need to have multiple sensors. There are different areas of the foot, so the heel, the midfoot, and the toe that we need to detect. And more than likely, just one of them is not, one sensor in each region is not going to be enough. In between the 4 sensors, we have these IR proximity sensors that can tell us how far the foot is displaced from the footrest. So to give us an idea, as I said, if it's, say, the foot is tilted, or if it's completely off the footrest. But it's not very useful just to monitor the data. We really need to be telling the user what's going on. So we have also developed a concept of the foot-safe user interface with visual alert options that could include visual, it could include a sound option. And this is something that we want to work with our advocates to get an idea of what is the best for them. Next. So this shows you the flowchart that we have so far developed. We have the foot plate data that we're collecting in real time from the foot-safe sensor on the foot plates, monitoring foot position in real time. And then we take that data and transmit it via Bluetooth to calibrate the data so that we can then implement a detection algorithm, which tells us, is the foot in a safe position or if it is not. We can then alert the user if the algorithm is detecting an eyelid, and we can display data, safe or unsafe, as needed. Next, please. This shows you our current prototype, which has been built for lab use. It's working towards being a commercial prototype, but at the moment, what we're doing is testing it in the lab. We can record data from all 76 centers at 10 Hertz, so we're getting very rapid data updates. And as you can see, the middle image shows you the raw numbers. So if you are an engineer or an GP, you may want to see the numbers. But if you're the end user, what you really want to know maybe just not what are the numbers involved, but what is my foot safe in a safe position or not. So we have a graphical interface as well. The red foot showing, oh, this is your foot is unsafe, and the grey image showing that it is safe. As we said, we have it currently set up so we can upload it to the cloud wirelessly, so that then the clinician can look at that data, not necessarily in real time. Not every clinician wants to know what's going on immediately for everybody, particularly if they have a large caseload. Next, please. At the moment, what we are doing some in-lab testing. As we said, we have this interface which shows safe foot position. And you can see here that this is an unsafe position. And this is Sean's feet on foot safe, but not in a safe position. And we can see that both feet are towards the edge of the foot plate. That's an unsafe foot position. If we wanted to look in more detail, we'd be able to look and see what the pressure distribution was as well. But the main thing is to tell the end user there's an unsafe position going on. Okay, next, please. So this shows you twice the speed, what happens when for Sean, when he raises his foot plates, and you can see how it monitors the pressures in real time. And now I think I turn it back to you, Kristy.
Thanks so much, Gav. I'd just like to point out too that his foot spontaneously got into that position hanging on the edge of the foot plate after descending from a prior run. So we want to just move ahead. How can I click around it and ask you guys whether you think there's value for wheelchair users in the eyelid detection concept. This is sort of a new idea. We think, obviously, we're biased, that it has a great deal of potential. And our team thus far has been very volunteer oriented. We've done all the work that we've done with $50,000 worth of funding from the VA. And it's really interesting that, I'm sure everybody here that does research is familiar with the funding struggle. And the people reviewing grants don't necessarily realize the clinical importance from our perspective of this issue. And so we are very curious to see what people doing clinical practice in seating specialty clinics feel about these injuries. So thank you guys for that feedback. And we'd like to kind of wrap up going into the Q&A session by asking, well, first off, reviewing a few things. You know, among our options here, in terms of validating our algorithm, those are things that we need to do. We want to understand whether our users are able to balance, you know, the safety settings versus alarm fatigue. We need to look at what are the display preferences, as Kath mentioned, and how would people prefer to receive alerts? Would they like a haptic signal through an iWatch, Apple Watch, or would they prefer to use their iPhone? And are there any adaptive features native to the iOS or Android platforms that can be helpful and would be preferred by users? So the next question we have is, which smartphone interface do you think you would prefer? So you would just want to click on the picture if you can see it, and say which one you think you would like. And while you're doing that, you know, you'll notice that one of these has an option to contact a caregiver. Another option that you could have might be something like contact your seating specialist. We think that given those long lags often in getting a referral back to a seating clinic, in getting repairs made to wheelchairs, in getting clinical issues addressed, that this might be a really valuable thing to have happen. So one of our projects that we have done, I'm going to go ahead and move forward, is to start thinking about what a clinician interface might look like. And this is a very early draft, you know, it talks about who the care team members could be, notifications. At the bottom, you would see, for example, examples of a quote patient name. These are fake patient names, team members primarily, with runs on the device. And then hypothetically, the clinician could then download the data remotely through the cloud to understand what was happening. For example, was the pressure distribution wrong, for example, if somebody was developing a hotspot. So a big question that we have is, would you want your clients to be able to reach you immediately if they were having eyelid problems or if they sustained an injury? That's really important for us to know as we talk about this further. I know it could be definitely intrusive to some people to be getting pinged if they were having a lot of problems with their seating. And I think it might be something where really you're not going to know until if and when you use it. But it might be a nice option to be able to provide to your seating clients. So we'd like to consider, you know, the clinician user interface as something that would be potentially valuable to the user, particularly with a spinal cord injury. All right, so we've had a decent number of responses. And that kind of takes us into our next, which is open response. And this is going to make a word cloud if anybody responds, but we're curious to know what reservations, oops, we got some people that are texting, have about using this type of technology. And so if you can just say, you know, do you think it's intrusive? What do you think? Do you think it's a great idea? Do you not have any? But what sort of concerns do you have about implementing foot position detection in the wheelchair systems? And I would add, while we have been focused on the power wheelchair seating, we have spoken with manual wheelchair users who have the same problem. And those people often say, you know, yep, my foot came off. And I have one woman who was an attorney, and she was rushing to a court case and had to like stuff tissue in her shoe because to stop her foot from bleeding. So, yep, these are all great questions, and so we hope that this has been a thought-provoking presentation, and I see we've got a lot of comments in the chat. So we're going to go ahead and open that up. And I'm going to go back to the beginning. Okay. So Ryan Buslag, a PT at the VA, asks, would we mind sharing product details for the honeycomb padding that we use for hair protection for the user with flexor plasticity? I'm confident that Steve Mitchell will reply to you. Steve, do you want to just speak up and unmute yourself and say what you're...
Actually, I replied to that already. That was ordered from Supercore.
Supercore, great.
The honeycomb.
All right, and then they asked, how did you secure a strap around the thigh leg to reduce adduction?
That was an Innovative Concepts toe strap attached to a Permobil Type G lateral using their standard hardware.
All right. And then Megan asks, does it work only with iOS devices? And the answer is right now, yes. We would ideally like to see it integrated with both Android and iOS. But for many of our users with spinal cord injury and tetraplegia, the iOS devices are superior in terms of their adaptive technology, and the control functions are easier to use, particularly the verbal controls. So we do hope that, like I say, in the future. Cloudy Neverends says he thinks to connect the wheelchair system would be complex, and we would have to have an independent alt drive to achieve that. We agree. Replied, it would be great to integrate these with chair electronics, but we really would have to get buy-in from wheelchair manufacturers because they have, proprietary hardware and software, and they're all going to be a little bit different. And we also recognize the fact that we don't really think that footsafe should be able to stop a wheelchair on a dime. It comes off. What if they're in the middle of crossing the street? So we recognize that there is a gap between notifying the person of the foot coming off the foot plate and then being able to correct it. But at this point, I think that being able to call a caregiver, we agree. Yes, I think that was Megan. That is exactly kind of what we're thinking. Text your caregiver. If you don't have a caregiver, call 911. And also, Steve makes a very great point, which is that once a device is validated for regulatory standpoint with the FDA, it can be difficult to change it. Faith Savage comments, how would this work with the padded foot plate, and would it negate pressure reduction from the sensor sheet? That's absolutely true. And you would not be able to do those two at the same time, but that's kind of where we stand with all of this. So we have about 6 more minutes. If anybody has any other comments that they would, or questions they would like to put into the chat box, we would love to answer your questions. All right, somebody asks, they're curious about the incidence of false alerts, especially due to uneven terrain that can exacerbate foot position changes. And we do have thought a lot about that, and that there needs to be a way to factor that in. And so these are pieces of the data analysis and the algorithmic assessment of that data that would be built as this technology matures. It isn't present at with the current prototype of the application, but we definitely think that filtering is going to be really important, right? And it does assume that the client has a smartphone, and I would argue that in this case, the smartphone, if they didn't already have one, would be provided or should be provided as part of the system, because it's a safety feature in this case. So let's see what other comments we've seen here. Right, and so this person comments about reservations for alert fatigue as if they're also getting alerts for wait shifts. Kath, do you want to comment about your thoughts on that?
Yeah, sure. So there's always a concern. Anytime you're getting pinged 15 times a minute, you end up switching it off. So that's part of what we want to do with user groups, is to ask, what is it you want to see and how often do you want to see it? Because every time, if you get pinged every time, that may well lead to alert fatigue. But if, for example, the clinician only gets pinged when there's a series of displacement, so you're seeing a pattern, that might be more useful for the clinician. For the user, if they're getting regular alerts, then that can also potentially prompt them to contact their clinician and say, there's a problem here. My foot plates are not working the way I need them to. So yeah, it is something that we're very well aware of. I think it's a problem that affects every type of smart technology. Is more information is not necessarily always better information. You have to be smart about how you provide it as well.
And if I might add, Dr. Buggy, the way we kind of envision is there'd be different levels of alerts, so that the ones that really pose an imminent danger where there's absolutely no reading at the foot plate because the foot's been totally displaced would be a greater level of severity to warn the user. We also believe it probably should be, the user interface should be customizable so that the user has the options to kind of set it up as they want to. If somebody habitually crosses their legs in their chair, then they may want to have a feature to be able to mute those danger alerts when they're sedentary and they're just changing their positioning.
Thanks, Steve. And that could also include setting the sensitivity of the device. And then someone else wondered about its value as an evaluation tool. And I would argue also potentially an educational tool for people as they're first learning to use wheelchairs. So those are, I'm going to see if there's any other comments here. But yeah, the person commented about that alert fatigue and using Lucy and virtual seating coach. In an ideal world, we would all come together and develop an integrated system so that people really knew, what their situation was. We do want to try and do as much user experience work as possible as we hopefully move forward towards commercialization, because we don't want this to be, we want this to be useful. We don't want it to be technology that's abandoned. I think that we're pretty much up at the end of our time by my clock.
I'm just going to read the code, and then if you feel like you can get another one in, the CEU code is in the chat, and I'm going to read it a few times. Z1D LEN. Z1D LEN. One more time, it's Z1D LEN. And it's also in the chat.
Thank you so much, Rachel.
Thank you all. Great presentation.
Hope to hear from some of you if you after the meeting, if you have suggestions or other questions that you didn't get in. I'm going to keep the chat open just in case anybody has any other comments. I think that makes the end for us. Are our moderators going to close the meeting down, or do we need to stop it?